Thank you very much. I will go slowly, and when I can, I'll say things in Hebrew, but it's a challenge because this is about effective reassurance. And I really struggle to find the word in Hebrew for reassurance. I've got lehargia and I've got leasher, and neither of them are quite right. But let me start by saying that beautiful building down there is my university, Royal Holloway University of London, officially the most beautiful campus in England, voted. So always lovely to beat Cambridge. And please come and visit. And I only wish I could be with you right now in person. And I need to acknowledge that I have no conflict of interest. I do not work with pharma at all. And that most of the work I'm going to show you now was collected by my PhD students and is funded by Eurospine or by our research councils. Okay, so our big question together is, when we don't know exactly what's happening with our patients, uncertainty can't just be removed. How do we make them take care of themselves better in self-management? How do we get them to accept what we tell them? And when they're so anxious, they can't hear or accept our prescribed exercises and advice, how do we win them over? And this is what effective consultation-based reassurance is. It's the ability to calm people down, to bring them to the point where they can work with us, and also make them feel that they can control the problems that they have. This is what I'm going to try and answer. What is this thing, this animal called reassurance? How does it affect outcomes in patients, especially with low back pain? To be fair, I've now worked with more than low back pain, so you can shove in here shoulder and neck quite happily. We're not quite sure about knees yet. And very importantly, that last little bit, do we have some groups where we need to change the way we interact with them? And does the science support all of this? So, importantly, reassurance is actually mentioned by pretty much all the guidelines. So I've brought you the old European guidelines. They haven't changed much. And you can see that for backs, they recommend providing reassurance to say nothing is dangerous, movement isn't dangerous, rapid recovery can be expected. In other words, don't worry and get better. In primary care, it's important to reassure patients through adequate information, educate them, give them information. For neck pain, we're told that neck pain is a very common problem, and that's the bit we need to tell people. Lots of people have this, so you don't need to worry. For shoulder pain without red flags, tell them that it's self-limiting. In other words, you're going to get better quickly, kind of within the next 6 months. That's a little less reassuring for patients. 6 months is actually quite a long time in the life of most humans. So when we're pretty sure that things will get better, reassuring patients and fostering, making this positive expectation in patients is a very good idea. And we do this very well. I'm told by my colleagues in physiotherapy, osteopathy, and chiropractic that when a patient walks into the room, they almost immediately know whether they're going to be somebody who will easily work with them and get better quickly, or whether it's going to be a complex case. And over time, they get this body of experience to identify this in patients. So when we're sure things are going to get better, it's a good idea to tell people that they're going to get better because they will and all is well. However, what about patients who might not get better? And with chronic pain, an awful lot of them don't get better, or get better a little bit and then bad again, better and bad. So those who've had persistent pain for ages and ages are probably not going to be cured. When things are more complicated and we're not sure what's going on, what are we supposed to say to patients? Because we know from the research that saying to patients, I have no idea what's going on here and I'm not quite sure how to help you, isn't very helpful. In fact, patients hate that. So although there's all this emphasis on reassurance and guidelines tell us to do it, actually there's very little research on reassurance. It's one of the most neglected areas of research. I came to this about 10 years ago. having looked at all the predictors for low back pain and realizing that if you take all of them together, the psychosocial and the physical, we can only predict somewhere between 30 and 50% of how people will be down the line, 12 months down the line. So there's a big bunch of stuff happening that we don't know about. And I started to think, maybe it's us as practitioners. Maybe it's something that we do that we need to do a little bit better, or we need to be careful not to do. So in the first instance, and you can see this research really starts 12 years ago. So I have a big body of research on this, and I'm hoping to answer questions if I possibly can. In the first instance, I had to go out and find out what on earth reassurance was. Luckily, my good friend Stephen Linton from Sweden published in 2008 a very nice definition. So reassurance, I'm not going to read this, I'm just going to tell you my take from it. Reassurance aims to reduce anxiety in the patient. But what it is what we do, our behavior, our explicit behavior, what we say, how we touch, and our implicit behavior, the expressions on our face, our gentle choice of word, how we move, how we respond to people, our ability to empathize and to convey this to the patient. And the first body of work I did was published, myself and my team, I can't possibly take all the credit here, was published in Pain in 2013. And this is a vast systematic review. So what I tried to do here is I tried to find out whether reassurance really predicts patients' outcomes. Now, in order to do that, inevitably, you need to look at research that has a timeline, research that measures what happens in the consultation and then follows patients up to see how they do. And within this, we're looking at two types of reassurance. Cognitive reassurance up here, which is basically what you tell people, education, and affective reassurance, which is the more implicit stuff I talked about, the empathy we give and the communication and the rapport that we create. So our review was just prospective cohorts. We set it in primary care because we were very interested in early stages at the time, but I can tell you in secret, because it's only just been accepted to press, what happens in secondary care. And these are groups where high uncertainty exists. So low back pain is in here, as is shoulder pain and neck pain, but we also have irritable bowel syndrome and we have chronic fatigue. What we don't have are things like cancer, mental health problems, diabetes, asthma, where there is a clear diagnosis. So areas with high uncertainty, where they measured consultation aspects, so either videos or tapes of what happened in the consultation, sometimes questionnaires, and then they analyzed in reference to patients' outcomes later. And as I said, we split what happened in the consultation into these two types. Affective reassurance, you can see the 4 points here are really around empathy. I can see that you're suffering when you say that to a patient. I'm really listening to you and actually do it. I really understand what you're going through and I really care about what's happening to you. All of those are about rapport and empathy. Now I've put these ones in red. You can rely on me to help. I've seen all of this before. I know what I'm talking about. You're going to be fine. You don't need to worry. This is a bunch of reassurance that sometimes we do, which I'm putting in red because we have reason to suspect that it might not be a good idea to do this, especially with people who actually are not going to get better. And here you have cognitive reassurance from my experience with people like you, clinicians from all musculoskeletal areas, you do fantastically well. So giving an explanation that accounts for what the patient describes. This is what I propose to do, giving a management plan. Here's what I think might happen in the future if you do what I say and if you don't do what I say. And here's what you can do about it, what you should take responsibility for as a patient. So we're really strong in this. Some of us are strong in this, and unfortunately, many of us do this kind of red stuff. So what did we find in our systematic review? We had 4 very good studies and 4 less good studies, which found a strong positive association with immediate outcomes. Patients were more satisfied, they felt enabled, that means they're more able to control their illness, and reduced concerns the more you gave them these explanations and plans in simple language that they understood. And we had some very good studies showing that even after 3 months, there was a correlation with improvement of symptoms. So what we can draw a conclusion from this is that giving good explanations and discussing with patients a management plan is very good for patients. This is not a surprise. Here's the surprise. So affective reassurance. Affective reassurance, this is, remember, a combination of that empathy, but also of the you can trust me, it's all going to be okay, more generic reassurance. In other words, it's general, but it's not based on anything which relates to that individual. In fact, it's more about how amazing the practitioner is. So what happens with affective reassurance? Well, in the short term, patients are very satisfied, although some of them are a little bit more worried, because if you tell them, trust me, you're going to be fine, and they've had pain for ages and ages, there's a discord and they're a little bit worried about it. But look at this one. 5 studies with high quality showed that affective reassurance is associated with higher symptom burden 3 months later. It could be that giving those generic promises that things will be okay is actually a very bad idea. So cognitive reassurance improves patient outcomes. Affective, at best, predicts satisfaction, but possibly is bad for at least some of our patients. So which aspects of affective reassurance are backfiring? Well, I've already told you my hunch, which is generic reassurance. So we developed a body of work in primary care, which took this further and further. In the first instance, we did what everybody should do, a good starting point, talk to patients. And we did a series of qualitative studies interviewing patients about what they thought would reassure them. These people had seen mostly family physicians, but also quite a lot of physios, less osteos and chiros. They felt very strongly that they wanted that empathy, that sense of being listened to and cared for. But the most important thing to reduce their worry was cognitive reassurance, explanations, and a care plan. So we went on to develop a questionnaire. If you're going to do research on reassurance in consultations, you better be able to measure it in a reliable and valid way. And our questionnaire, I'll show it to you in a second, measured both cognitive and affective reassurance. And it's based on the systematic review on the one side and what patients told us reassured them on the other. And then we went back to complete our own prospective cohort. It's not huge. Our more recent one is quite a lot bigger, but these are 147 people consulting for low back pain for the first time ever. And then we follow them up for 3 months. We measure what happens at the consultation, and we measure outcome. Here's the questionnaire. So the reason it's in a table is so that I can show you how we grouped it. And this went through very, very strong validation. It's all published. If you just Google my name, it will all come up. So the data gathering is something that's very important to patients. They want to know that you really looked at all the aspects of their care. They really, really love hands-on. But they need to voice their concerns. They need to know that you've listened, and you know that they need to know that you've heard because you summarize back to them what you've heard. Relationship building. This is empathy and rapport. Show genuine interest. The ability to put a patient at ease so they talk freely, and show that they understand your concerns. So not just hearing them, but showing that they relate to them. Here's my generic reassurance one. This is the one that I think might not be a good idea to do. Tell you that you don't need to be worried, tell you that everything should be fine, reassure you that they have no serious concerns about your back. Now that might be okay in acute back pain, but in chronic back pain, it's not a good idea. If people have had it a long time, I'll show you what happens. And here's the cognitive reassurance. Just as you know you do it well, explain what treatment offers, make sure they understand the treatment plan, check that the explanation is understood. All of this from the patient's point of view, because the perception of the patient is what predicts outcomes, not necessarily what actually happened in the consultation. This is an important point. It's the patient's perception, what they walk out from your consultation feeling. Okay, so next I said that we did our own prospective cohort. Here it is, and that's quite recently published, 2018. Let me show you the findings. They're quite surprising. So this is in primary care. As I said, we measured in baseline all the things that we thought really would predict outcome at 3 months: pain, function, age, gender. We thought maybe practitioner gender and the matching of genders would predict. It doesn't. Marital, education, employment. The start back, I'm hoping some of you are familiar with the start back. I know that in the audience is a wonderful researcher, Israeli researcher, Noah Ben-Ami, who has just translated the start back to Hebrew. So those of you who want to use it can now. And the start back has 5 items on it: fear of physical activity, anxiety, pain catastrophizing, and depressive mood, which are the strongest psychological predictors for poor outcome in back pain. And here's our consultation-based reassurance questionnaire, satisfaction and enablement, and all this 3 months later, we hope, predicts pain, function, whether they ran back to their GP for their back pain, which they shouldn't, how much medication they took, and how depressed and anxious they are. I'm going to call this distress because it's a combination of depression and anxiety. None of it is psychiatric in any way. It's to do with pain. All aspects of reassurance are closely linked to satisfaction. There is no question that how you do, what you say, how you talk, your rapport is very, very strongly linked to satisfaction. The correlation is 70%. R square is 70%. So we better do things right, hey? For people with higher psychological risk on the start back, so at least 3 of depression, anxiety, catastrophic thinking, and fear avoidance, generic reassurance was associated with increased depression 3 months later. Let me show you that on a graph, because this is the important thing. So, here you've got our people who don't have any depression. They've got back pain, but they don't have depression. This is the blue line, yeah? And you can see that you can tell them everything's going to be okay, and probably it is kind of okay. And they start not having much depression, and then they have almost none at all after 3 months. Here's our group that had depression when they came in. They're not really at the level of caseness, what we call caseness for depression, but they're not at a stage where I'd be happy. And when you give them a lot of generic reassurance, you tell them it's going to be okay, don't worry, they're even higher 3 months later. We think it's because you've said it's going to be okay, trust me, but it's not okay. So not only do they have the pain and the disability, but now they've also been betrayed by their practitioner. So maybe complex pain requires a different, maybe more reassurance of a different type in a different way. We are now doing research in osteopathic spine teams, and I'm going to go through this very, very quickly because I really want to leave plenty of time for questions if I possibly can. So I'm interested in people shouldn't arrive in orthopedic spine teams if they have musculoskeletal low back pain, but boy, they really do. So the question is, what happens when they get to these spine surgeons? The spine surgeons do their MRIs, look at the MRI and go, can't do anything for you, mate. And off they go again with nothing. They've gained nothing. And the question is, how do they feel? And can we give that message better? Again, we started with a qualitative interview of 30 people who have persistent low back pain, some of them for 10, 20 years. They went to these clinics, they consulted with people, and they were told you can't have surgery. And unfortunately in the UK, because we're not connected in that important way that Michael told us about earlier on, they're not even sent anywhere. They're sent out into a void. They have to start their journey all over again if they want help. This is what they showed us. They told us that to feel reassured under these situations, they want data gathering to be really well done. Read my case notes, please, surgeon, they said. Our surgeon said they can't because the case notes are this big sometimes. Be familiar with my history. Provide a chance to voice concerns. Ask me how I'm feeling, what I'm worried about. Make as many tests and investigations as you possibly can, which is, of course, against all the guidelines. Provide hand-on examination. The hands-on examination is so important for chronic people who are very worried that something's going on which hasn't been shown. Ask about my lifestyle. What about relationship building? Show empathy. Tell me you care. Listen to me. Build rapport with me. Let me feel that you know what you're talking about, that you're qualified and experienced. What about generic reassurance? Oh, our patients were so upset when they got the message of no need to worry. It made them so angry. You're telling me I don't need to worry, and I've had back pain, which allows me not to work, not to help my kids. I've had that for 10 years, and you tell me not to worry? They were really angry about that. Don't tell them that. What they want is validation, which I think is Reassurance, but I'll tell you about it in a second. Understand my suffering and tell me that I'm not exaggerating and that you believe me. And our best friend, cognitive reassurance, provide explanations in terms we can understand. My orthopedic surgeons were not very good in talking English. In other words, they talked orthopedic surgery, whatever that is. And even I don't understand most of the time when they explain to me what's going on. Discuss care plans, even if you're not offering treatment. Follow up with a letter, because when people are anxious, they can't listen. So follow up with a letter. And sometimes offer an open follow-up. If you need to, phone me. I want to say something about validation, because validation is, for me right now, the cornerstone, the most important thing in a good consultation. What is validation? It came to us actually from research in mental disorders. It is a message to patients that their emotions, their thoughts, and their behaviors are valid and understandable in the current circumstances, that they are believed, they're not mad, they're not exaggerating, and they are suffering, and it's understandable. Honesty and integrity are really important here. And let me tell you why I think it's so important. And I think this is the last thing I want to tell you about. This is a beautiful little study from Sweden in which the experimenter took students, in fact, but they had pain complaints, and he asked them to hold buckets of water for 10 minutes, like this, arms out. Now, if I even ask you to put your arms out now for 10 minutes, you will feel it, believe me, but imagine holding a bucket full of water for that time. It really, really hurts. Half of them got reassurance. They got these messages that pain is understandable, and the others didn't. The ones that got reassurance reported less pain and could hold the bucket for longer. And that's nice, but that's not what made me excited. What made me excited is that the researcher at the end of this bucket experiment gave them a memory test. He simply gave them a list of words and asked them how many they could remember afterwards. People who got reassurance remembered more words more accurately than those that didn't. Now, this is amazing, because I want you to imagine all of those bits of advice, explanations about exercise, explanations about the pain that you tell patients about during the consultation. If you reassure them and validate their pain before you do that, the likelihood of them remembering what you've said is higher, significantly higher. So this is very, very important. And definitely worth doing. In summary, consultation-based reassurance is measurable. We can actually measure it. It's valid, it's reliable, and most importantly, it predicts outcomes. Generic reassurance, trust me, I've been here before, might be a little bit risky, especially when people are complex, depressed, have had pain forever, have seen a million other people. Validation is probably the most important thing you can do during the consultation. And there is some stuff showing that once you validate, people's cognitive ability to hear and comprehend is increased. From the patient's point of view, the most important thing is to have a clear explanation in a simple language that they understand about their pain, and to have options for managing it, because we do tend to jump in and say, you will do this. Instead, we could offer them options, and then they buy in, and then the chances of them doing it are much higher. Patients need to accept our explanations, so we need to listen to their beliefs as well. I've spent a lot of time training practitioners around the globe, including in Israel, to improve reassurance. And this impacts, we believe, on the burden of low back pain, not only in terms of the person suffering the low back pain, where we can reduce low mood and reduce disability, but we also have now evidence that it actually reduces the amount of care they seek and the time off work that they need to take. Thank you very, very much. And I'm so glad to see that there is plenty of time for questions, which I really hope, please do ask.
Okay, thank you. Thank you very much, Tamar. In other words, when I say to my patients, trust me, I'm a doctor, that's not so good, huh?
It's absolutely fine when your patients are okay anyway. You know, when your patients feel that they can handle their pain and all they need is a little bit of help on how to handle it, what we call the kind of SMART approach, where all they want from you is to give them specific exercises, when to do it, how to do it. They're not carrying a burden of catastrophic thinking and worrying. Then you say, trust me, I'm a doctor. They go, tell me what to do. You go do this, they do it, they're better. Unfortunately, an awful lot of our patients aren't that. They're actually people who are deeply, deeply worried, not just about their pain, but about their life. And then, trust me, I'm a doctor. When their pain hits them again, you're not there.
Right, okay, good. So we have 144 participants, and who wants to ask a question? Go ahead. Bella or Michal, are people allowed to talk, or?
No.
They can put questions in the chat.
They can write the question.
Okay, anybody got questions?
Tamara.
Yes, hi.
Yes, thank you very much. I would like to ask a question. First, I will comment that the main challenge is to reassure the doctor, because sometimes when we work in primary care, reassuring the doctor is the first stage, because sometimes we are not sure that everything is okay. And sometimes our anxiety and our fear that there is something we are putting a lot of stress on the patient. But when we in primary care, when we know there's nothing serious about this low back pain, how do you identify the timing when the patient is ready to understand that it's a chronic pain and not, because this is the main challenge, because the patient keep on asking me, but what about the pain? What about my disc? What about my sciatica? How do you treat this? And he always says, when you take off my pain, I will be okay. Don't worry. I'm not depressed. I'm just in pain. So what is the timing? How do we identify the timing?
You've actually asked two questions there, and they're both brilliant questions. I have these 10 questions that I always get asked, and those two are always in there. One of them is, what do we do about patients who are chasing a cure? Because a lot of our patients are literally looking for somebody to just take the pain away. And if we don't take the pain away, no problem. They're just going to go to the next one and the next one and the next one. And they're in this endless chase of a cure. And how do you teach patients that there isn't a cure? I use, some of you might have seen my video, the plasticine video. I use the plasticine video because it's, for those of you who haven't, it's on YouTube, Google my name, it will come up. The plasticine video is a metaphor for the fact that practitioners, once pain is completely enmeshed in your life, it is impossible to pick it out. And then the question is, how do I live with this pain? And sometimes it's almost impossible for the patient to accept this message. But I hear all the time, I get messages from around the globe from people using the plasticine video. And a really important one I got from Denmark was a physiotherapist who said the patient could not figure out anything positive in her life. But I brought the husband in, and the husband took the plasticine from her and started saying, here's our puppy, here's that, you know, and so you can find a way to work most of the time. A problem is timing. So timing is, when do you do this and how do you do it within the constraints of the 10 minutes that you've got? Or in England, we literally have 10 minutes for family physicians. The first thing is you let patients talk at the beginning. The biggest mistake that, I know you know this, the biggest mistake that people make when they start consulting in the real world is they think that they have to follow every single question that they learned in medical school rather than let the patient talk. And patients don't actually talk for enormous amounts of time. I love one of my trainees said, I like saying, we only have 10 minutes and I really need to know what's going on so I can help you. So tell me everything I need to know. What a great start. And then the patient talks. And then when the patient finishes talk, that's the bit to do the validation. And once you've done the validation, you can have a conversation about whether it's possible to remove the pain or not. Sometimes we get it wrong. I have to say there's no right or wrong here, because sometimes you think there is no answer and there is no cure. And actually there is. I mean, people's bodies in the world are very weird. And sometimes people just get better, even though we told them they weren't. But the vast majority of the time with chronic pain, they don't. And it's a question of learning to live with chronic pain. I hope I answered you.
Tamar, I have a question from Dr. Jakob Fogelman. He's a family practitioner or a specialist in family medicine. And he asks, what is better, to reassure orally after validation or to write down a structured written rehabilitation consultant summary plan? In other words, to speak to the patient or to write it, and is there one better than the other, or should
you will get a sense of when to do what. And again, I don't want to be too prescriptive here. I think that the connection between you and the patient, the eyes, the bodies, the we are doing this together is incredibly important at early stages. And very often patients tell me in interviews that, oh, he turned away and started to write, and I just felt I didn't want to tell him anymore. So that writing can be not a good idea. Sometimes the patient is very upset, even crying, and needs that moment. And a good way of giving them a moment is to say, I listened very carefully and I want to write down what I think are the main points, which I'll read to you in a minute, because I think it's so important that I remember all of them. You're giving them the reassurance that you listened, but you're also giving them a bit of time out, and you have a little aid to your own memory. But generally speaking, writing while somebody's talking to you, hey, would you like it?
Okay, thank you very much. Dr. Robert Satran, also a family practitioner and specializing in pain medicines, writes to us, there is a temporal aspect to reassurance. It is accomplished in more than one encounter and feels more like a process. I feel the ratio of affective to cognitive changes along the process.
I think that's true, very true. Thank you for that. And also it changes depending on the patient and depending on where the patient is at that point in time. Often people say to me in training, how do I know when the patient is really, really depressed? Give me the recipe, the psychological recipe of now I shouldn't treat because they're too depressed, or now I should change. And I always say the same thing, you know, what you feel in your stomach, your intuition is absolutely more important than anything I can tell you. If a patient walks into a room and starts talking to you, and within 5 minutes, you feel that all the energy has been sucked out of the room, you know what I'm talking about. You have the problem in the room with you right there, and you have to rethink how you're going to reassure and how you're going to treat. So your intuition is your best guide. And then you have to just develop the confidence and have the tools to follow that intuition.
Okay, thank you very much. Dr. Mashrawi asks, and how's your Hebrew? Should I give it in Hebrew or in English?
Try in Hebrew. Let's give it a try.
Okay. אשמח להתייחס לתחושת הביטחון של המטפל עצמו, ועד כמה זה ישפיע על מה שהמטופל מאמין בו בסוף. In other words,
great question. I got it. Okay. So how does the confidence in the clinician affect how the patient responds? I'll tell you why I love that question. I love that question because in all of our professions, mine, psychology, yours, in general practice, physio, chiro, you name it, we have gurus. We have a whole load of gurus, and I could name them, but I'm not gonna. Now, our gurus are amazing at having effects in what they do because they are incredibly charismatic and confident. The problem is, there's two problems to this. One, we can't clone them. So we just can't have a whole bunch of them doing what they do. And when we test it empirically, it never works quite as well. So the first thing is, the extra confident gurus are few and far between. The other thing is the one that I said before. When the pain hits the patient later on, you're not going to be there. The more confident the practitioner, the more dependent the patient becomes on them, because that is how relationships work. Think of a Newton law, yeah? You know, being in the middle where it's real shared dynamics is quite difficult. We tend to go either the practitioner is more dominant, sometimes really the patient is more dominant. So there is an issue of overconfidence. There's an issue of underconfidence. I think, yeah, but within that, I will say that we still get the correlation of people who are charismatic and confident, they have better outcomes.
Thank you. Dr. Victor Douani is a chiropractor. He asks, is the reassurance still effective if you as a doctor avoid the patient's questions, such as how long till my pain will go away? So
if you duck, yeah, okay, that I call that ducking. You know the word ducking? It's leaning down as the ball goes over your head. So from my experience, you know baseball, you get 3 strikes.
Yep.
Yeah. So it's exactly the same in consultation, and I can show you the evidence. So the first time the patient's there, and if you're just talking, if you're having the agenda of finding out what you want to find out, you're going to get nowhere fast. The patient says, "Oh, my pain is terrible, and I honestly, I can't sleep, I can't eat, it's awful, I'm really, really suffering." And you go, "Okay, is it worse in the morning or in the evening?" And the patient says, "Oh, it's there all the time. I just don't know what to do with it. It's terrible. It's awful. It's killing me." And you go, "Have you tried ice?" That's 2 strikes already, because what the patient is really telling you is, I am in agony. I am suffering. As a human being, I am in a state of suffering. And until you turn around and dare to open that Pandora box and say, "Tell me about it. You said that it's awful. Tell me what awful is for you," you're striking all the time. You're not actually addressing the patient's agenda. And strike 3, they'll stop talking to you. They might come back, but my hunch is they'll look for somebody else who listens.
Okay. Ofer Baruch, he's a chiropractor, very, very experienced one. And he asks, is there a difference between genders or ethnic groups in terms of reassurance?
Yes, there is. Excellent question. And thank you for asking that. There's a plethora of research about gender differences. We're rubbish on ethnic groups. We should be better, but we're not. On genders, anything from the way you sit to the words you choose is gonna really matter. Even the humor that you use is gonna matter. Men and women have very different. In general, you know, this sounds like I'm being sexist sometimes. In general, men and women laugh at different jokes. Yep. And our patients want to be treated differently depending on whether they're men and women. And in terms of the groups which we call hard to reach, which are the ethnic closed groups, we have in London, for example, we have a big Somali a group of people. We can't even do randomized controlled trials with them because the women are not allowed to enter the trials with the men unless we have women only, run by women and not addressing certain things. We can't work with people at all. And their understanding of what pain is completely different. If you've worked with anybody Chinese, you'll understand that our ideas of somatization are fundamentally different from Chinese ideas of how pain manifests in the body and how psychology manifests in the body.
Fantastic, thanks. Nadav's a physiotherapist, and he asks, he writes in Hebrew. I'll try in Hebrew, let's see how you do. First of all, he says, Ezo harza madhima, an amazing lecture. And then he asks, לדעתך, איפה רופאי משפחה יכולים לקבל הכשרה, ידע נוסף, כלים פרקטיים, על מנת להעביר את המידע לגבי קבלה של כאב בצורה טובה יותר? So where can family practitioners, say in Israel or anywhere?
Yeah, there's not an awful lot. Yeah, there's not an awful lot in Israel at the moment. All I can say is I've already worked twice with physiotherapists. So I think I've now trained close to 600 physiotherapists in Israel. I haven't worked with family doctors, but invite me, I'll come. Usually it's a 2-day workshop followed by a more advanced 2-day workshop. It will be a pleasure.
Negev, did you write that down, Negev? Put that down. We're having tomorrow.
Yes.
Can I just point out that so far every person who's asked me a question has been a man. Come on, women, ask me a question.
You're right. And okay, so I think we're going to go for the last question now. There are lots of more questions. I'm looking for a woman. Sorry, guys. I'm looking for a woman. No, you're right. It's all men. Let's see if there's a woman here. No, so we're going to go for our last question, and it's going to be from Simeon. Simeon's an osteopath, originally from London. He would have loved to speak to you, but because of technical details he has to write down. What does the type of therapy influence the outcomes? What's the role of placebo? Oh my God, he's asking a lot. The streamline of the ISMM and our logo is touching the pain. Is there any evidence that reproducing patient symptoms in the therapeutic encounter has better outcomes?
So many questions, and they're also great. Does the therapy influence, is there a particular therapy that works? No, in back pain, nothing. In other words, okay, physiotherapy and CBT work better than anything else, tiny effect. No, we need to actually use everything we've got and work with individuals, take a little bit from here and a little bit from there. That's the first thing, is that there is no silver bullet, certainly not for chronic low back pain. That's question number one. Question number two was, I think, something about touch. Now, I don't sit in the conservative side of things here. Now, the research on touch falls into two groups. There's the group that looks at touch in general and whether it's healthy for us in psychology. Lots of research with animals, research with children. There is no question that without touch in general, we die. It's not just that we grow up a bit sad, we actually die. And then there's the research in pain, where we haven't managed to prove that putting hands on makes people better. So there's a big group of people, especially in physiotherapy, who are now doing the hands-off kind of approach or advocating it. I don't sit there because I talk to patients. And if you speak to patients, they will tell you that nothing is more important to them than you continuing to put your hands on their body to find out what's going on and make them have that very small pain relief, even if it's just for one day. So I advocate that one.
Oh, okay, and for everybody else, there will be a lecture later by Dr. Irit Fogel-Weissman, and she will talk exactly about that. Tamar, we want to thank you very much. It's been wonderful to have you, and the lecture was excellent. I'm sure everybody was very excited. I can see from the participants that nobody's left. So nothing more than that. Negev, do you want to say something before we go on to the next lecture?
Thank you very much. It was our pleasure to host you here.
Please ask me back.
And we hope to meet
I'm begging.
We hope to meet in September in Israel.
That would be so nice.
Okay.
Have a wonderful conference, and thank you for asking me.
I shared your
stay. It's gonna most of it's going to be in Hebrew, but we've still got some more English, and you're welcome to stay as long as you want.
Thank you.
I shared your videos, your YouTube videos, Pain and me, and the two others also in our WhatsApp group of the conference, so everyone will be able to see it.
Thank you, and please note they are translated into Hebrew.
Thank you very much. Wonderful.
Okay. Goodbye, everybody. Stay safe.